Hello, good morning, friends. Today we'll be discussing some congenital swellings of the neck. So before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, which we can discuss. So, and in today's topic, we'll be learning about three swellings, that is the branchial cyst or sinus of fistula, along with that thyroglossal cyst, and lastly cystic hygroma. So let's get started. These are most of the congenital swellings or occurring in the earlier age group, and we'll see them one by one, and these are commonly involved in the head neck region. So the branchial cyst or sinus of fistula. So these are cysts are fluid filled lesion which develop from the vestigial remnant of the branchial cleft, that are the embryological remnant, and these are lined by squamous epithelium and contain turbid fluid which may contain cholesterol crystals and are generally non-transluminant, and treatment will be complete excision of these lesion. So we'll see the embryology. So these develop during the branchial apparatus. These develop during the 2nd to 6th week of the fetal life, intrauterine life, and as we can see in the diagram that the second arch grows caudally and covers the second, third and fourth cleft. So on the outer side, external side, there is cleft, and in the internal side there is pouch, and the cleft is made of the endoderm as written, and the cleft is made of the ectoderm, and the pouch is made of the endoderm, and the arch is made of mesoderm, that is the between connective tissue part. So this covers the second, third and fourth cleft, second arch, and forms a groove that is known as the cervical sinus of His, which is lined by the ectoderm, which normally obliterates. If this does not obliterate, it will result in a branchial cyst. If post drainage, there is a chance of it might become a branchial sinus. And if the endoderm breaks down of the second branchial pouch, then it will lead to a fistula, branchial fistula. So there is no fifth arch which you have to notice. It is 1 to 6th, and the first arch, cleft and pouch, they merge to form the ear apparatus. Then the branchial fistula, how does it proceed? It pierces platysma, curves medially around the hyoid bone, and passes between the external carotid and the internal carotid. Also, it passes close to the hypoglossal, glossopharyngeal, and also the sternocleidomastoids nerve, that is the 11th cranial nerve. Deep to the posterior belly of the digastric, it lies. Now the branchial arch derivatives. So the first arch, the skeletal derivatives are the malleus incus and the sphenomandibular ligament and Meckel's cartilage. Muscles will be muscles of mastication and mylohyoid, tensor tympani and tensor palati. Then the nerve will be trigeminal nerve, artery will be maxillary artery, and it is known as the first arch or mandibular arch. Then we have the second arch, which is the hyoid arch, which will have stapes, styloid process, stylohyoid ligament, and part of hyoid cut. Then muscles of facial expression, platysma, artery will be facial, and muscle will also be the nerve will be facial, the artery will be hyoid and stapedial artery. In the third one, we'll be having parts of hyoid cartilage, then the stylopharyngeus muscle, nerve will be glossopharyngeus, aortic arch, artery will be internal carotid. Then the fourth one, where will be laryngeal cartilage in the skeletal, muscles of the pharynx and the larynx, superior laryngeal nerve, right subclavian artery and aorta. Then in the sixth arch, we have the nerve supply by the recurrent laryngeal nerve. Now we'll see that the derivatives of the pharyngeal folds, that is the cleft, the first one will be forming the external auditory meatus and the rest will be forming the neck. And the derivatives of the pharyngeal pouch, the first one will be forming middle ear, that is the auditory tube, and the auditory tube, 2 will be forming supratonsillar fossa, 3 will be forming thymus and parathyroid gland, 4 will be forming thymus, parathyroid gland, and ultimobranchial body, that will give rise to C cells of the thyroid. The first branchial cleft cyst, these are type 1 or type 2. Type 1 are near the external auditory canal, and type 2 will be near the mandible. As you can see in the diagram, the second branchial cleft cysts are the most common, as you have seen, and these are along the anterior border of the upper third of the sternocleidomastoid. The cyst will be above and the fistula will be below. Third will be similar to second cyst, but fistula courses posterior to the carotids and pierces the thyrohyoid membrane and enters the larynx, terminates in the lateral aspect of the pyriform fossa. The fourth is very rare, which may in the region of thyroid or mediastinum. So this was all about branchial cyst and sinus and fistula. Now we'll be seeing another topic. So now we'll be discussing thyroglossal cyst. So thyroglossal cyst, the embryology, that it is the vestigial remnant of descent of the thyroid gland from the foramen cecum of the tongue to the location of the thyroid. That means from the tongue it is coming down near the thyroid region from the foramen cecum, and the descent is converted to the tract and is remnant, will be resulting in disorders. So the tissue arises, the tissue bud that becomes the thyroid gland, the bud, which is known as the thyroid analgae, could be median or lateral, arises in the midline as a diverticulum in the floor of the pharynx, and it does it when in the third week of gestation. So this pharyngeal analgae or the median thyroid analgae, this is the point and starts in the foramen cecum, and it contains cells of the endodermal origin, and it will give rise to our thyroid tissue. So in the diagram, as you can see, from the buccal cavity near the foramen cecum, the median thyroid analgae start descending through the thyroglossal duct, and it becomes bifid, and it traverses up to the thyroid region near the fourth pouch and cleft. The fourth pharyngeal cleft and pouch will be forming the ultimobranchial body along with the neural crest cell. These are called the lateral analgae and will be forming the part of the C cells of the thyroid and posteromedial aspect of the lobe. The third one pharyngeal cleft and pouch will be forming the inferior parathyroid and the thymus. So the thyroid glossal duct migrates caudally, comes down in close proximity through the developing hyoid bone. It could be anterior, posterior, or even through it. And the duct is initially hollow, which gets obliterated around the 5th week of gestation, and disappears by the 8th week. And the median and the lateral thyroid analgae fuse by 5th week and becoming thyroid. The follicular cells, which are derived from the lining of the thyroglossal duct, develop by 8th week, and colloid formation and thyroid functioning starts by 11th or 12th week. And the distal aspect of the thyroglossal duct may be retained as the pyramidal lobe of the thyroid lobe. So if this fails to obliterate the thyroglossal duct, then it will result in thyroglossal duct cyst, sinus of fistula. So the congenital cervical anomaly, it's a congenital cervical anomaly with persistence of the thyroglossal duct, as you have seen. It is considered tubulodermoid and can occur anywhere in the migratory path of the thyroid, as we have seen and we'll see in detail. Based on the location, it will be divided into types, starting from the foramen cecum, just below the foramen cecum, which is the least common. Then we have in the floor of mouth. Then we have suprahyoid. Then we have subhyoid or infrahyoid, which is the most common site of these thyroglossal duct cysts. Then it can again trace down up to thyroid near the cricothyroid area, which is the second most common. So histological, these will be having pseudostratified ciliated columnar epithelium along with squamous epithelium. It may sometimes have the heterotopic thyroid tissue and sometimes maybe the only functional thyroid tissue, like in 20% cases. So this cyst fluid, which may be having cholesterol crystals, mucoid material, or epithelial debris. So clinical features, since these are childhood swellings, appear in the childhood, but sometimes even in the late adulthood, as in the 6th and 7th decade. These are small midline swelling, but may occur slightly laterally on the left side. When they arise adjacent to the thyroid cartilage, they may lie slightly on the one side of the midline, that is on the left side. Transmission may be there, may not be there. Sideways mobility is there, but vertical mobility is not there. These are generally asymptomatic unless they are infected by the bacteria which are oral. It moves with deglutition. It may or may not move with the tongue protrusion. Then these are below the hyoid, as they may have lost attachment with the tongue. Differential would be subhyoid bursitis or sublingual dermoid. Now we see the complication, that is the recurrent infection, carcinoma, the rare chance of papillary carcinoma, SCC, Hurdle cell anaplastic. MTC is not seen in thyroglossal cyst due to the embryological origin. Role of the total thyroidectomy is controversial, but is indicated when there is large tumor with additional thyroid node and having evidence of cyst wall invasion or lymph node metastasis. Then it may result into a thyroglossal sinus or fistula, depending on the scenario, may be spontaneous or iatrogenic after the drainage when it gets infected, or incomplete removal after surgery. Clinical features will be of the sinus and fistula with hood similar fold of skin just above the fistula due to overgrowth of the neck tissue, and there will be pronounced dimpling in the skin on of the sinus on the protrusion of the tongue, pronounced dimpling of the skin of sinus on the protrusion of the tongue. So how will we investigate this? Thyroid imaging may be done to confirm the presence of normal thyroid tissue with help of USG, thyroid scintigraphy, and TFT. Even higher two-dimensional, three-dimensional imaging with help of CT and MRI. So management would be cyst-trunk procedure, which is the en-bloc cystectomy and excision of the central hyoid bone, and we go and excise up to the whole tract up to the foramen cecum. The transverse neck incision over the cyst, subplatysmal flaps. The cyst is dissected up to the hyoid bone and remove the central part of the hyoid bone. The muscles sternohyoid, sternothyroid, geniohyoid, and mylohyoid are divided and separated. Central 1 centimeter of the hyoid bone is resected along with the tract, and the tract is identified, dissected up to the foramen cecum, ligated and divided. So this is how we do the cyst-trunk procedure and remove the cyst with the hyoid bone up to foramen cecum. Then we have the thyroglossal fistula, for which we have cyst-trunk surgery, which is similar. Now we'll be seeing the last topic for today, that is the cystic hygroma, also known as cavernous lymphangioma. It is the congenital condition resulting from the failure of the lymphatic sacs to develop and drain it with the lymphatic system, resulting in formation of the focal lymphatic cyst, that is sequestration. So it will be having clinical features of swelling in the posterior triangle of the neck, axilla, posterior mediastinum and groin. These are partially compressible but brilliantly translucent, which is the diagnostic clinical feature. They have a mosaic appearance. So the presentation in the antenatal period, the patient's mother may have polyhydramnios, the fetus unable to swallow the amniotic fluid. There may be difficulty in the childbirth, resulting in obstructed labor due to neck swelling. These present generally by the years of 2 age. Neck swelling may extend to the axilla or mediastinum in 10% of the cases. Then the cyst is lined inside by the endothelium and contains lymph. These are generally unilocular but may be multilocular and may infiltrate the surrounding structure to distort the anomaly, especially what? The tongue, the floor of mouth and the deep neck. Adjacent connective tissue, then there can be extensive lymphocytic infiltration, and histologically they may contain nests of vascular tissue, and these are poorly supported by vessels, so may bleed and result in sudden enlargement and discoloration. It can result in infection of staph or strepto. Respiratory distress due to airway compromise may result in perinatal asphyxia. The treatment is exit procedure. What is this exit? Where we use ex utero intrapartum technique. We'll be going intubation when the baby is already attached to the placenta, or we even have to go for tracheostomy. So the procedure here goes side by side to the cesarean section or a normal delivery. Intubation in the tracheostomy. Then we have the management. We could try for image guided sclerotherapy, that is alternative, but cystic excision may be done when the aspiration and injection sclerotherapy is inadequate. Conservative excision and unroofing of the cyst with repeated partial excision of the residual cyst and sclerotherapy. Total removal of all gross disease may not be possible due to extensive nature or intimate relation with the nerves and the blood vessels, and is not necessary because they are always benign. So we have to be careful while dissecting because there is high chance of nerve or vascular damage, and we have to take care since it's a benign swelling, and we have to weigh the morbidity as comparison to the benefit of the surgery. Now we'll be seeing capillary lymphangioma, which is failure of the embryological remnant to connect to the efferent channels, resulting in cystic lymphatic malformation. That will be simple capillary hemangiomas, which would be truncal, mesenteric, intestinal and retroperitoneal. So this was all about the three main topics, that is the cystic hygroma, thyroglossal duct cyst, and branchial sinus and fistula. Thank you for listening. Keep studying, keep growing. And once again, I would like to thank Chandana Shri ma'am. I have shared the link for the notes below, which can be downloaded from there. And see you in next video. Thanks for watching.